Welcome to JAT Chat, presented by the Journal of Athletic Training, the official journal of the National Athletic Trainers Association. I'm Dr. Shelby Baez, an assistant professor in the Department of Exercise and Sports Science at UNC Chapel Hill, and the co-host of JAT Chat with Dr. Kara Radzak. Today, I have the pleasure of being joined by Dr. Ryan McCann, who is an associate professor in the Masters of Science in Athletic Training program at Old Dominion University. Dr. McCann is the lead author of Assessments Used by Athletic Trainers to Decide Return to Activity in Patients with Ankle Sprain. Ryan, thank you so much for joining me today.
Thanks, Shelby. Nice to be here.
All right, so let's go ahead and start with a very broad question for our listeners. What do we know about clinical outcomes after ankle sprain in helping with that decision to return to sport?
Well, first and foremost, and I don't think it's any surprise to people listening, is that ankle sprains are really associated with a lot of different impairments. And that's very well established. We know that there's pain, there's swelling, there's problems with range of motion, laxity, strength, balance. And we know that impairment profile is very heterogeneous. So, different patients present with different impairments. But what we've seen recently in a lot of the literature is that patients with ankle sprains very often are reaching that return to activity time point before these impairments are resolved. So these impairments are persisting once they've re-entered some of that high-risk activity, whether it's sports or some other type of functional activity. In some of the more recent studies, we've also seen that some of these impairments might increase their risk for developing recurrent ankle sprains or chronic ankle instability. And if we look at the chronic ankle instability literature, we can see that a lot of people with CAI have these impairments ongoing for months or even years.
Yeah, so when thinking about this, the ankle sprain population, we see them going back to sport even prior to these impairments being resolved. And that seems a little counterproductive, I think, as we think about being clinicians wanting to make sure our patients are ready to go. So what prompted the decision to want to explore athletic trainers' methods and trying to make sense of some of these impairments and determining when a patient's ready to return to activity following an ankle sprain?
Yeah, a lot of our justification for doing a study like this was sort of rooted in the things that I just described. We've seen in some of these previous studies that the patients with ankle sprains who are reaching return to activity with residual impairments are still often being cared for by an athletic trainer or some other medical professional. So it really made us think, what are the athletic trainers actually doing with their patients prior to and after return to activity? So we really wanted to start analyzing the AT practices. So certainly we could look at things like, the rehabilitation plans, and I think there's plenty of work to be done in that area. But as sort of a jumping off point, we wanted to ask, first and foremost, are athletic trainers consistently evaluating impairments in these patients before they reach that time of return to activity? And if they're not, maybe that's a potential contributing factor for why these impairments remain unaddressed and persist for as long as they do.
And can you just give us some insight into your approach in starting to answer that question? What was the methodology? What type of study did you do to try and answer that question?
Sure. Well, we actually started with a preliminary study that, we're not talking about that one specifically, but it was a qualitative research study that we did a year or two before this larger survey study. So we did some interviews with some clinically practicing athletic trainers and just did some open-ended interview questions to get an idea of what it is they're doing. And that really sort of helped frame some of the questions that we ultimately put into this survey. And so this survey was really designed to be sent out to clinically practicing athletic trainers. We ultimately went through the NATA in order to do so. That allowed us to cast a really wide net. We initially sent this survey to 10,000 clinically practicing athletic trainers. And ultimately, after we looked through all the responses and the inclusion and exclusion criteria, we ultimately wound up with 541 responses from athletic trainers. So we think we wound up with a pretty good sample to answer these questions.
Yeah, I think I read it was like about an 85% response rate.
Yeah, very good. In terms of people who actually, opened the survey and started answering questions, we got about an 85% response rate. So very good.
Yeah, so if any of our listeners are receive any future requests for surveys, so please complete those along the way because it really helps us develop our own research moving forward. So along the lines of talking about, you had this qualitative study first that helped to inform some of the questions specifically on the quantitative piece. Can you just give some insight into what was included on this quantitative survey to help
Sure.
make sense of what athletic trainers are using?
Yeah, the first thing we really wanted to know was the background of the ATs. So we really dove into some demographic questions. Things like age and gender were important in there, but we also really wanted to know what was the education level of the ATs who were responding. Whether it was the degrees that they've earned or the programs that they've completed. We wanted to know how much clinical experience they have. We wanted to know what clinical practice setting they were currently in. How many ankle sprain patients do they see within a given year? One of our exclusion criteria, or inclusion criteria, I should say, was that they had to treat at least one ankle sprain patient within the previous year. But, we wanted to know, was it just one, or were they treating 10, 20 every single year? And then one of the other key pieces we wanted to know was, what is their familiarity with these ROAST guidelines, which we haven't really talked about yet. So just to kind of clarify, these ROAST guidelines stand for Rehabilitation Oriented Assessments. And this is sort of a consensus guideline that was put together by the International Ankle Consortium, which is a collection of ankle researchers and clinicians from across the world who really put together these recommendations for how we should go about evaluating ankle sprains. So after we got past the demographic questions, we really wanted to ask about these outcome domains that were within the ROAST guidelines. So just generally, were you evaluating pain, swelling, range of motion, orthokinematics, strength, balance, gait, physical activity level, ankle-specific patient-reported outcomes? And then once we got past that question, we wanted to know, if you actually assess a given outcome domain, what are the specific assessment techniques that you're using? So for example, if you say that you're evaluating ankle range of motion, okay, great. Are you using goniometry? Are you using weight-bearing lunge test? Just a visual inspection, something else entirely? That's really where we took the final questions there.
So it really sounds like a comprehensive survey to give insight into, are people using these ROAST guidelines? And then if they aren't, what are they using to help? Go ahead.
No, I was going to say, we tried to make it as comprehensive. Of course, I'm sure you know that anytime you get through one of these surveys or any study, really, it brings up more questions than answers.
Definitely. So what did you all find? What was the results of the survey?
Yeah, so to sort of sum it up, and there are a lot of results. For those out there who will actually go and read the paper, you'll realize there's a lot of appendices in there. We really tried to present as much of the data from the survey as we possibly could. So there's a lot to sift through, but I'll try to sum it up as best I can. To start with some of the outcome domains, right? So just overall pain, swelling, range of motion, et cetera, et cetera. We actually saw that most of those domains were assessed by a high percentage of athletic trainers before these patients reach return to activity. If we looked at things like pain and range of motion, we saw that over 90% of ATs were assessing these things. We look at some of the other outcomes, swelling, strength, balance, gait, it was more like 75 to 90%. Still very high, but maybe some room for improvement. The ones that were a little more alarming, things like orthokinematics, physical activity level, and ankle-specific patient-reported outcomes, we saw that no more than 35% of ATs were assessing those outcome domains in patients. When we look beyond the outcome domains into the specific assessments, we wanted to know about whether they're using the recommended ROAST guidelines or if they're using something else entirely. We saw things like swelling and range of motion were mostly done by visual inspection, which we know have limitations because there's no quantification of visual inspection and there's some major issues with reliability of that assessment. Similarly with strength, we saw that over 95% of athletic trainers assessing strength relied on manual muscle test, which we know also has some limitations because it's not a quantification, even though you can get that rating scale. The use of things like handheld dynamometry, where we can actually get quantification, was used by a much lower percentage. I think handheld dynamometry was less than 5% of athletic trainers. So I think there's some limitations maybe in our ability to quantify some of the outcomes that are even being assessed.
So one of the things that I think was interesting to identify was this, I guess, lack of assessment of pharmacokinematics, physical activity levels, and patient-reported outcomes prior to clearance. Can we get some insight as to maybe why we see this in our athletic training facilities and our athletic training populations, that we aren't assessing those particular outcomes?
We did actually do some follow-up assessment questions with this. And actually, the paper that we're discussing has a companion paper that's also been accepted JAT. I don't know how the publication's working, if they're coming out together or if one's going to be delayed. But when we look at some of the barriers and facilitators for using these ROAST guidelines, a lot of the respondents said that it was a lack of knowledge or previous education, and that's why they didn't use some of these assessments. So things like arthrokinematics, a lot of them didn't know that they were supposed to be assessing it, or they didn't know how to go about assessing it. Same thing with patient-reported outcomes. They weren't familiar with some of the ankle-specific assessments. They weren't really comfortable using them, or they didn't feel like it was feasible. Maybe it was a time-related issue for a lot of them. And to be honest, that's not a major surprise, considering we've seen previous literature very recently that shows that a lot of athletic trainers do not use patient-reported outcomes. So our findings there actually align pretty well with what we thought we already knew.
And as a psych researcher, it kind of breaks my heart just a little bit that the PROs aren't being included. But it sounds like you've identified a couple of barriers as to why athletic trainers aren't necessarily using these tools and techniques in their practice. What were some of the facilitators, though, for athletic trainers to use arthrokinematics or PROs or assess physical activity levels?
Sure. We looked closely at the demographic characteristics. We sort of broke it out by the varying levels there. And we found quite a bit of variation, but to sort of sum it all up, we found a few demographics that really help facilitate. One was a higher age or experience level. So athletic trainers generally who are older, had more time under their belt, they were more likely to use some of these ROAST assessment techniques. We also found athletic trainers with higher levels of education. So whether that was based on the degree that they earned or the program they completed, more education led to a greater likelihood of using these outcomes. It seemed that athletic trainers in non-traditional settings also were more likely to. So whether it was industrial, rehab clinics, MD practices, that seemed to facilitate as well. Probably thinking that might be related to the amount of time they have with a given patient. Considering traditional settings like secondary schools and colleges, you might be sort of bombarded by the number of patients that you have, and you might not have a ton of time to actually do a comprehensive assessment, where some of these non-traditional settings might actually allow for that. And then the last demographic characteristic that was fairly consistently a facilitator was their familiarity with the ROAST guidelines to begin with. So if you had read the paper, if you had known something about it beforehand, you were more likely to actually use it. So that actually was not a very big surprise. Now, for those who used ROAST guidelines, the specific assessments within there, a lot of them said that their previous knowledge or previous education was a facilitator. Also, a lot of them said that the accessibility or availability of some of these outcomes was really favorable. One of the nice things about the ROAST guidelines is that most of the assessments in there don't require a lot of expensive equipment, don't require a lot of space. They can be done fairly simply. The only one that really has a major expense associated with it is the handheld dynamometry.
Hopefully this podcast can provide another layer of education and encourage athletic trainers to pick up the ROAST guidelines if they haven't picked it up just yet. So Ryan, what's the next step here as it relates to future research or clinical practice in this space? Where do we go from here?
Sure. I think there's a ton of directions we can go with this. In terms of research, I think we need to continue looking at the practice habits of athletic trainers. We have some preliminary studies that are in review at other publications. We've seen through some of our preliminary research that, use of immobilization might be beneficial to preventing recurrent ankle sprains. We've done some comparisons looking at time loss versus non-time loss ankle sprains. We've seen that, patients that actually take some time away from the injury and are not immediately returning to activity, they might have some better long-term outcomes. Even if those ankle sprains are more severe, they tend to result in better outcomes. So there's some really interesting stuff that we'll have coming out in the future. Other than that, though, I think we need to look at, some of the care and rehabilitation protocols that athletic trainers are using. What specific items are in there? Are you using balance training? Are you using manual therapies like joint mobilizations? And then sort of as a follow-up to the study we're discussing is criteria-based return to activity decisions. We have an idea now of what assessment techniques athletic trainers are using. We still don't have any idea how they're interpreting them. Right. So if you take a balance assessment like the STAR Excursion Balance Test, what's a score that constitutes readiness for return to activity? We really don't know what athletic trainers are using to determine that. So that needs to be investigated in the future. I'd say for clinical, one of the facilitators that we consistently saw was the previous knowledge or education for using these ROAST guidelines. So we certainly need to make sure that these assessment techniques are included within educational programs. It's important that students understand what these are and know how to use them when they come out and start their clinical practice. For those who are currently practicing clinically, I definitely recommend conferences and workshops that go through these specific skills and that cover the contemporary literature. But then even just keeping up with the current literature yourself, if you find these expert consensus recommendations, read them and then think about how you can factor them into your clinical practice. Again, we consistently saw that ATs who were just familiar with the ROAST guidelines were more likely to use it. We know that there are some other barriers to using these ROASTs, so things like time and cost are issues. We think there might be some ways to mitigate some of that. We know there are modifications for some of the ROASTs. For example, patient-reported outcomes. You could take something like the foot and ankle ability measure, and you could use the QuickFame, which is an abbreviated version of that. It's a time saver. Same thing with something like the SEBT. It can be whittled down to something like the anterior reach. It's a much shorter test to conduct, but it still gives you some valuable information about dynamic balance. We know that the one major cost associated with these is the handheld dynamometer, and you can get them for hundreds up to even $1,000. We know that's an issue for a lot of clinical sites, but there are other options we can use to quantify strength. A crane scale or a hanging scale is a great option. It's really just a generic load cell you can pick up at any hardware store. People use it to weigh suitcases or other items. Those things cost around $30 to $50, which you can set that up with some straps or some chains, and you can make some strength assessments out of it. So it's very practical, and we know that it's valid and it's reliable for assessing muscular strength.
Well, thank you for that comprehensive assessment from a future direction from a research standpoint, but also just very clear, tangible pearls from a clinical standpoint and what athletic trainers can do right now to start to enhance their abilities to assess return activity. Can you just provide us a take-home point? What's the one thing that you want our listeners to get from your paper?
Sure. I think between our paper and then the research that's come out before it, we're starting to really realize that the comprehensive ankle sprain evaluation is really crucial to, number one, detecting the impairments and then making sure that they're resolved before that return to activity time frame, because we know that they can contribute to recurrent ankle sprains and development of chronic ankle instability. So really encourage athletic trainers to look at their assessment methods that they're using, see where they can be expanded or modified to more closely meet those expert recommendations.
And as a person who has chronic ankle instability, I really appreciate the work you're doing in this space. So thank you so much. And Ryan, thank you so much for joining me today. And to our listeners, this article is available free of charge by the Journal of Athletic Training. I highly recommend everyone go and download this manuscript in a future issue of the Journal of Athletic Training. Again, thank you so much, and we'll see you next time.